And so I just want to give a brief, we talk about uterine cancer, endometrial cancer, but just really important to kind of go back to basics to talk about what exactly it is and the terminology that we use and that you might hear. And so you might hear the terms uterine cancer and endometrial cancer, and those terms are used interchangeably. I'm going to show you a picture. If you go to the next slide, actually, the uterus is broken into two parts. And so you'll see the main body of the uterus is the larger part of the uterus on top there. That's typically what we think of that holds a baby when we're pregnant. The lower part is the cervix. And then on the ends there and the out, you see the fallopian tubes and the ovaries kind of coming out to the side. And so the uterus is kind of the main body, that bigger portion there, but the lining of the uterus is called the endometrium. And that's typically the most common cancer that we see form inside the uterus. And so you can see that kind of ugly little piece of cancer there inside the uterus. And that's coming from the endometrium, the lining of the uterus. So that's why you might hear the two terms interchangeably. So when we think about, how do we even get this cancer to begin with, there are certain risk factors for uterine cancer and endometrial cancer that Dr. Welsh has the next slide there.
Can you see?
Does it go to the next slide?
Oh.
Oh, there you go. Perfect. Thanks. And so very important, just because maybe one of these applies to you does not mean you are going to get endometrial cancer or uterine cancer. But just important things, the most important thing you can do is establish, annual care with an OBGYN, your gynecologist, so that they know you. And then they can, take note of some of these factors and kind of be on the lookout. So some of these factors, one, I say estrogen use, and not all hormones are bad, right? Hormone replacement therapy is not all bad, but if you are using high doses of estrogen while you still have a uterus and aren't using the more protective progesterone, which then protects the uterus, then estrogen is actually what causes the lining of the uterus to grow. And then the more it grows, the more risk there is for it to kind of grow out of control and form a cancer. So always talk to your doctor and your gynecologist if you are on hormone replacement therapy. Again, most of it is safe, but make sure that you're asking, okay, why am I on this? Am I on the right combination of things? Am I on the right dose? Other risk factors. So it's important to know your family history. Do you have a strong family history of breast cancer, colon cancer, uterine cancer, ovarian cancer? Again, talking to your gynecologist, this is part of your annual visit every time you go to get a family history. They're uncommon, but sometimes if you have a strong family history, you might be referred to a geneticist. There are certain genetic mutations or syndromes such as Lynch syndrome. You might hear that puts you at risk of colon cancer and uterine cancer. Early puberty and late menopause, that just means you start having periods really early and go into menopause really late. So the more times you have periods, the more cycles you have, the more risk you are at something kind of going awry and causing a cancer. Low frequency of menstrual cycles. So again, if your menstrual cycles are really abnormal, meaning that they're really long, and I'm not talking 35 days instead of 30, but if you're going 2-3 months without having a period, that causes the lining of the uterus to grow and grow and grow, which gives it more chance for abnormal cells to start to form. And really the obesity and diabetes. So obesity is kind of the biggest risk factor, especially in our US population these days. The reason for that, and I think a lot of women don't realize this, or I don't think about this either, but fat cells in our body make estrogen, and estrogen makes the lining of the uterus grow. And so when women are overweight, that's actually one of the biggest risk factors for uterine cancer and why we're seeing such a big rise of uterine cancer in the United States. So again, just because you might have one or two of things on this list doesn't mean you're going to have uterine cancer, but that's why it's important to kind of understand your body, understand your cycle, talk to your doctor about these things. So if we go to the next slide, kind of what are the symptoms of uterine cancer? I think it's important to note that there aren't any screening tools. It's like a pap smear tests for cervical cancer, but if you go to your gynecologist every year for your annual visit, there's no certain screening tool. There's no ultrasound, there's no biopsy that's routinely done to check for uterine cancer. But there are certain signs and symptoms to talk to about your doctor if there's a change or something new comes up. So if all of a sudden, every month your periods are regular, but now you're having really heavy or long abnormal periods, definitely talk to your doctor. So if you go through menopause and you haven't had a period in 5, 10 years, and all of a sudden you notice bleeding, I mean, any bleeding, even if it's dark brown, light spotting on a paper towel, one time only, you go to your doctor. Any sort of bleeding, brown, red, pink, one spot, heavy after menopause, you go right to your doctor, because that could be a sign that there's something abnormal inside the uterus. Pelvic pain. So something, if you've never had pelvic pain before, but all of a sudden you're 60, 65 years old and you're having new pelvic pain, definitely let your doctor know. The uterus is also down in the pelvis. It's close to your bladder. It's close to your bowel. So I always ask all my patients at every visit, are you having any, changes in your bowel function, changes in your bladder function? Because that might be a sign that something's wrong down there. And pain with intercourse. Again, if you never, had pain with intercourse before, but all of a sudden things are feeling differently, not saying you definitely have uterine cancer, but something to talk to your doctor about so they could start an appropriate workup. I never want to say that any form of cancer is good or that there's any good thing about cancer. However, uterine cancer is one of those that we typically catch early, because women do have a sign or symptom that prompts them to go to a doctor, that prompts us to find it early. So the most common symptom and sign being postmenopausal bleeding. You haven't had bleeding for 10 years, you go to your doctor, and typically because of that bleeding, we're able to catch it early. And that's usually stage 1 disease. And because of that, we're usually the most common treatment of uterine cancer is surgery to take the uterus out. Right? We want to get rid of the cancer. And so that's kind of one of the most common procedures I do, which is a hysterectomy, to remove the uterus and the cervix and to remove the cancer itself. Many times that's curative on its own, but sometimes women do need radiation and or chemotherapy afterwards, based on kind of what the final pathology and the final cancer cells actually look like inside the uterus. If we see the cancer is initially diagnosed at a later stage, so stage 2, 3, or 4, where it's kind of spread outside the uterus. Again, sometimes you can still do surgery to remove the cancer, but sometimes if it has spread too much, it's actually helpful to do chemotherapy and or radiation first to shrink the cancer, and then maybe do surgery at a later date when there's a higher chance that you can kind of remove everything that's there. So again, I'm going to let, that's the end of my part, kind of as like the basics and overview of uterine cancer. And I'll turn it over to Dr. Welsh for the next part.
Thank you, Nicole. It's so glad to be here and discuss this. And I think you did a good introduction of what uterine cancer is, what are the symptoms that, we should be looking for. But even when we get to the doctor early, how do Black women fare? Well, Black women had more than twice the rate of deaths from uterine cancer from 2010 to 2017. So we're getting cancer at a higher rate than comparative to the white women in this country. Not only are we getting it at a higher rate, we have mortality is higher, and it's increasing by almost 2% a year overall, with sharper spikes among Asian, Hispanic, and Black women. And this is according to a recent JAMA Oncology article. According to that article, the study for uterine cancer death rates among women ages 40 and up, there are disparities. The death rate for Black women is about 31.4% per 100,000 women, compared to 15.2 per 100,000 women for white women, and in the same age group. And according to the study, the death rate for Asian women was 9 per 100,000 and Hispanics 12.3. So if you look at those numbers, Black women have much more of a higher mortality rate. In the study done by the National Cancer Institute, researchers looked at women who used hair products compared to women who didn't use them. And I know recently this has been a big ad on TV and radio stations. Black women were known for using jerry curls, hair perms, and other straightening chemicals on their hair. And they reviewed over 33,000 people between the ages of 35 and 74 between 2003 and 2009. The group was racially and ethnically diverse. And the link was even stronger in people who reported using straightening products often. And these people were more than 4 times and used the products more than 4 times in the past year. These women were more than twice as likely to get uterine cancer than women who never used a straightening product. So if you used hair straighteners in the past, which Black women are known to do, this study is saying that you have a higher chance of getting uterine cancer. They estimated that 1.64% of women who'd never used these products would get uterine cancer by the time they were 70 years old. But people who use them regularly had a 4.05% risk of uterine cancer by that same age. Why do Black women have a higher chance? Black women usually get a different type of endometrial cancer. Sometimes it, as Nicole said, uterine cancer usually starts in the lining of the uterus, and Black women usually have cancers that don't necessarily start in the lining, and these are more deadly. So what's the area of focus? Black women, and sorry for that typo, have a higher incidence, as I said before, than white women. And older studies reported the opposite. So nobody really looked at it. Now, these studies did not account for the higher hysterectomy rate among perimenopausal Black women compared with white women, because in this country, again, we know that uterine fibroids affect Black women more than white women. And usually, one of the biggest surgeries for Black women is a hysterectomy. That's non-cancerous. So it didn't take into account all the missing uteri that Black women had, and it made it look like we don't get cancer. So it underestimated the true incidence of cancer in Black women. The most recent statistics from the American Cancer Society reported an absolute difference of 21% in 5-year survival rates, with 63% of Black women surviving compared with 84% of white women. Now, there are a lot of disparities that there's a lot of socioeconomics rather that owe to these disparities. In addition, Black women have an advanced stage that's more common than their white counterparts because we're not seeking treatment. We're not heeding the symptoms that we do have. We have non-endometrioid cancers, as I said, cancers that don't exactly start in the lining of the uterus. And Black women are less likely to receive guideline diagnostic procedures, less biopsies, less surgery. Black women are also less likely to receive definitive surgical treatment. Now, I don't owe all of that to the medical side. Sometimes Black women are reluctant to have definitive treatment. And I can say, as a Black woman, I was raised to think that if you cut open a body with cancer, you would die. And that's how my family, those were strong family beliefs and in the community. Black women are also less likely to be offered minimally invasive surgery. Minimally invasive surgery is usually done robotically with smaller incisions, less healing time. And now minimally invasive surgeons exist more widespread than they did before. But unfortunately, Black women are not offered these surgeries as often. Black women are also less likely to have lymph node sampling. They're less likely to receive chemo. Again, a lot of this is owed to societal beliefs. They're more likely to receive adjuvant radiation and more likely to be cared for by high volume uterine cancer surgeons, usually because it's more at an advanced stage. But lastly, Black women are less likely to have guideline compliant treatment. And this is twofold. This is societal beliefs and the lack of opportunity given by physicians in this country. All of this was published in a journal called the Obstetrics and Gynecology journal. So how do we prevent that? How do we prevent this disease? Cancer is not always preventable, but we can do some things to decrease our risk. Birth control pills, it's a very widespread misnomer that if you use them, you will get cancer. Birth control pills are actually protective of not just the uterine lining, but also your ovaries. Maintaining a healthy weight. A healthy weight is different for everyone, but as Nicole says, it is not highly known that those extra fat cells that we carry actually have estrogen precursors. And when we have more estrogen in our bodies than we're supposed to, you're at increased risk for not just uterine cancer, but other types of GYN cancers. Nicole also mentioned taking estrogen. Taking hormonal therapy isn't bad, but if you have a uterus, taking estrogen alone or estrogen byproducts that are sold over the counter, taking those alone will increase your risk of uterine cancer. Progesterone should be taken together with estrogen. Pregnancy and breastfeeding are also protective of uterine cancer. The less times that you have a menstrual cycle, the less likely you are to have uterine cancer. So what are the takeaways? Uterine cancer may present with abnormal bleeding, whether you're menopausal or premenopause. If bleeding occurs that's not your usual pattern, please go seek a physician. Treatment is more effective with early detection. New cases in this country have increased 12% and deaths have increased 21%. Black women are 2 times more likely to die. See a healthcare provider, again, after menopause, if you're bleeding after menopause, between periods, or even after sex. When it comes to cancer, early detection is always key. And when it comes to uterine cancer, just heeding the symptoms is also key. And that's what I want to leave everyone tonight.
Thank you both so much. Excellent information. We would like to open it up to questions. If people have any questions, you can put them in the Q&A portal. Let's see. One question, and Dr. Welsh, I think you covered this, but if diagnosed, what would be, I guess, the normal course of treatment one can expect, so they know that they're getting the complete treatment that they should be receiving?
I'm going to shift that question over to the experts.
Yeah. So I will say, when you have bleeding, it's most important to present to your primary gynecologist. And most of the time they do a biopsy, an ultrasound or a biopsy first. So most cancers are actually diagnosed by your general gynecologist first. And then once you have that diagnosis, you're referred to a GYN oncologist, such as myself. And when you come to the office for the first visit, we go over the imaging, we go over the biopsy. I show you lots of pictures and kind of talk about what that means. And as I had mentioned earlier, most of the time, we like to assume that if you haven't been bleeding for a long time, so I always ask, how long have you been bleeding? So if you've only been bleeding for, let's say, a month or a week, then I'd like to assume that the cancer is confined to the uterus. Most of the time it hasn't spread elsewhere. And so in those cases, we talk about surgery. And so the visit is very focused on talking about a hysterectomy, what it's like to remove the uterus, the cervix. And because uterine cancer most commonly presents in older postmenopausal women, we also talk about removing the fallopian tubes and the ovaries as well, which is a common part of the hysterectomy procedure. And so that's the main part of the surgery. The second part of the surgery for uterine cancer is the lymph node evaluation. And you'll hear a lot about sentinel lymph nodes. It's very popular in breast cancer literature. And so it's a way to kind of inject a green dye that travels to the first, what's called sentinel lymph node, that lights up green. And it's a way to take out just one lymph node in your pelvis on either side instead of having to sample all the lymph nodes, which puts you at risk of lymphedema and other complications during surgery. So routine surgery, or like a routine visit after you get a diagnosis, is usually talking about surgery, which is a hysterectomy, removing the ovaries and fallopian tubes, and the lymph node evaluation in postmenopausal women. And I'll say, so if I talk to a patient and they said, oh, I've been bleeding for 2 or 3 years, but because of COVID, I didn't go and see a doctor, or there was a delay in care, then I kind of, I order a CAT scan and more imaging to make sure that the cancer hasn't spread elsewhere, because we might not be talking about surgery in that area. So, I mean, in that situation. So really the history and talking to patients and really understanding what their symptoms are and how long they've been going on is a really important part of that first visit.
Now, if someone had another type of cancer, are they more prone to uterine cancer?
I think, like Nicole said, there's something called Lynch syndrome. So that's associated with colon cancer. So if you have a strong family history of either uterine and/or colon cancer, you could have an increased risk. Breast cancer, not usually associated with uterine cancer, nor is cervical cancer, but cervical cancer can absolutely extend into your uterus at times. So yes, you can be at risk for uterine cancer if you have another cancer, but not usually.
And is there a genetic component?
That falls into what Dr. Welsh was just talking about. So those syndromes and the Lynch syndrome and running in families is the genetic component that gets passed down.
And do you have any suggestions of how to listen to your body?
Well, that's a really good question. As women, the first sign is your menstrual cycle. So that's the first thing you're going to listen to. During a usual annual exam, I usually ask my premenopausal women, is it heavy? Is it crampy? Are there lots of blood clots? Is that normal for you? Is it regular? How many days are in between each cycle? Those are important clues. You should have at the minimum 3 weeks between each cycle, and it really shouldn't extend out more than 7 days. And it's truly abnormal to have to change your pad every hour or even every 2 hours. Those are abnormal. And as Nicole said, in menopause, there should be no bleeding at all. Now, I can say the majority time that women do have menopausal bleeding, it could just be due to the fact that the uterus and vagina are very what we call atrophic. So they're very dry and they tend to bleed. But any bleeding in menopause should be evaluated at all times.
Great. Thank you both so much.